attending physician, I am medical student. I will be on your service for the next month. Please feel free to ask me difficult questions so that I may learn all there is to know.
Yes, attending. The first patient is a 64-year-old woman who presented to the ER with shortness of breath. She says this has gotten worse over the past 5 months. She is coughing up a small amount of white phlegm. She has been experiencing nausea from the coughing. Over the past year there has been a 7-pound weight loss. She has a past medical history of asthma treated with theophylline and inhaled beta-adrenergic agonists and corticosteroids. She has smoked 1 pack of cigarettes daily for 44 years and drinks 1 alcoholic beverage daily. Physical exam shows a 2 cm non-tender lymph node in the right subclavicular area. Exam shows no other abnormalities. An X-ray of the chest shows a large right lower lobe density. A CT scan of the chest shows a 7.5 by 7.5 by 6 cm right lower lobe mass with some scattered calcifications. The lesion is against the posterior chest wall without clear invasion. There are right lower pretracheal, precarinal, right hilar, and subcarinal lymph nodes. There is a 1.5 cm mass in the right adrenal gland.
Resident physician, perhaps we should get a CBC with differential and a peripheral smear. She could possibly have B-cell lymphoma.
No, Sue. J. I mean T. No, medical student. This patient is not very likely to have B-cell lymphoma. While she has experienced weight loss common to many malignancies and shows signs of limited lymphadenopathy, she does not have fever, night sweats, or diffuse lymphadenopathy typically seen with B-cell lymphoma. That should be much further down on your differential.
Ah, you are so wise, resident physician. Perhaps the mass seen on CAT scan could be a lung abscess? Perhaps we should do a paracentesis to sample the fluid and look for white blood cells or bacteria.
No, medical student. I just mentioned earlier that this patient has not been experiencing fevers or other signs of infection. Also, would you expect someone who has an abscess to have a 5-month course? No, medical student, a lung abscess would present much sooner.
Ah, thank you, resident physician. I still have so much to learn.
Medical student, would you put mesothelioma high on your differential?
No, resident physician, mesothelioma would not be high on my differential. To begin with, you mentioned nothing in the history about exposure to asbestos, such as previous work in a shipyard, mining, ceramics, or auto parts that would make me believe that this woman was exposed to asbestos. Also, for mesothelioma you would expect to see pleural plaques secondary to ferruginous bodies lodged in the parenchyma. Well, the patient is a female above the age of 50. Perhaps she has metastatic adenocarcinoma of the breast?
Medical student, I'm impressed that you remember to think of breast cancer in your differential diagnosis. It is always something to consider in a female this age. However, as the attending physician pointed out, you would expect to see axillary lymphadenopathy. Also, once breast cancer has become metastatic, you would expect to see changes in the breast such as a mass, dimpling, nipple retraction, or body orange. This patient does not have any of these signs.
Resident physician. The mass in the right adrenal gland makes me think of MEN syndrome. Could she have a pheochromocytoma?
Medical student, does the history make you think of pheochromocytoma? She has not presented with episodic hypertension, anxiety, palpitations or night sweats. Also, there is no family history of endocrine neoplasias.
Well, she is not African American, she is above the age of 30, does not have bilateral, pituitary-lymphadenopathy, or hypercalcemia. She must not have sarcoidosis.
You are correct. That would not be very high on my differential at all.
Also, resident physician. I made a specific point to ask the patient about possible tuberculosis exposure, such as travel to endemic areas, close contact with prisoners or people living in close quarters. Since she does not have any of these risk factors, I don't think we should be concerned about tuberculosis.
Yes, medical student. It is good that you asked about all of those details during your 45-minute interview with the patient. However, she does not present with fever, night sweats, or bloody sputum as you would expect someone with tuberculosis to present. But, thank you for being so detailed. Attending physician, thank you for walking us through all of the differentials. However, given the presentation and history of smoking, I would put non-small cell lung carcinoma on the top of my differential.
What a great question, attending physician. The name of the 2 centimeters supraclavicular node is. It is. Virchow's node. It is significant because it is highly suggestive of metastatic cancer.
Good job, medical student. What other physical exam findings make you think of lung cancer?
Well, resident physician. The patient presented after a long, insidious course of 7-pound weight loss, cough with sputum production, and increasing shortness of breath. Her 44-year history of smoking is highly suspicious of lung cancer as well.
Yes, attending physician. I am familiar with the workup for a pulmonary nodule. When trying to evaluate a potential malignancy for a pulmonary nodule, you look for size, growth rate, presence of calcifications, border characteristics, internal characteristics, and location. Thank you, attending. I am glad that you are pleased.
Thank you for taking the time to teach me, attending physician. I really appreciate it.